We're a specialist testing, training and treatment service, which I'll come on to in a minute. But if we move on to the first slide, Glenn, one of the first point I would make is that the views that the things we're going to talk about today are the views of my own. They're based on a number of the experience of working with people, particularly with drug, alcohol, and mental health issues over the many years now. And one of the things with these, we're always very conscious, and particularly with the Mental Health Awareness Week, if we touch on any issues that sort of trigger things for people, we don't want people to go away in a worse state than they came in. And so please do get in touch with me straight afterwards if anybody would like to have any immediate questions or anything on a personal level, or about themselves, their friends, or the family. Please feel free to get in touch, and we can sort of talk through and see if we can either direct you to somebody who can help, or might be able to help directly. The other thing I'm going to say is regarding the statistics that we're going to show is the way we approach these things, and we can share the sources afterwards if people are interested. But the way we approach them is that we look at where there is reliable research data, and then we tend to comment on it from our own perspective and our own experience. And I think one of the key points we're going to touch on when we're talking about COVID is that actually there's so much noise and so much, so many claims and counterclaims that it's actually quite difficult sometimes to make sense of what's really going on. So the main sources of information we look at will be things like the ONS data, WHO data, some public health information, and also NHS direct statistics around issues such as prescribing, which I'll touch on later. So if we move on to the next slide, Ben. The starting point for this, for any discussions about workplace, has to be employers' responsibilities. Now in the UK, I quite like this definition, but essentially it's from ACAS. Essentially, employers will have a moral and ethical duty not to cause or fail to prevent physical or psychological injury. Now, when we're talking about mental health, which are sort of like quite often the unseen injuries, then this is, certainly before any outbreak, this was one of the key sort of developments and things that have come on the agenda as employers have started to see how important it is for the workplace. So the agenda we're going to look at today directly are things. First of all, we're going to start with section 1 will be where we are now. Then we're going to look at where we were, because we've got to assess that before we really sort of think about what the impact was. And then actually it's about planning for the return. Next slide, Glenn. So where we are now. What we do know is we're living in unprecedented times. We're living in a global pandemic which has affected every country and every community in the world. And one of the worst things with it is that actually there's so little known about this virus. It's really quite unique. Neither Ebola or SARS or anything like this has come along like it before. And the biggest problem with it is the lack of knowledge on it. We've been tracking this sort of science and these sort of data as it's been coming through for a few months, well, since it started really, since back in January, when people started becoming more aware of it, even though it was more aware in Asia from September. But what's been really interesting, almost every day, a new piece of research comes out which throws another sort of curveball in terms of how we think about the disease. So if we move on, what the impact is to people. The impact and the response to people is through governments is based on two main principles. You've got, and sometimes they conflict, sometimes they work together. First of all is the principle of an evidence-based response to the virus. Now, in real terms, the biggest problem, of course, is we know so little about it. And we still are discovering an awful lot of things. For example, CDC in Wuhan have identified over 30 different strains of COVID. So we're not sort of really dealing with a fixed point at any time. The other approach is around probability. What is likely to work in an environment? And actually, you can see the two different principles if we move on. Those two different principles, if we move on to the next slide, come into sort of sharp reality with two very different approaches to how you manage it. And essentially, companies have fallen, or countries and governments have fallen into two main sort of approaches. The first is the test, track and isolate approach. And I was on a webinar with South Korea this morning, talking about their experience, and that's very much, they were probably the key exponents of this, because they were so quick to get off the ground to get this isolated. Everybody tested very early before it got out of hand, tracked and then isolated. And the news from South Korea today is that there are 13 cases of COVID-19 in Korea, not deaths, cases, which really sort of prove, I would suggest, that that model has worked very well for South Korea. The other approach is the herd immunity approach, which is possibly, well, not possibly, is the approach that the UK government has taken. So if we look at this directly, if you can move on, Glenn. Herd immunity, or as our Prime Minister described it as, you know, we might need to take it on the chin. But the key issue here was that the aim was not to reduce the peak, broaden it, but it was to reduce it and to broaden it, but not suppress it completely. Working on the theory that the vast majority of people get mild illness, build up a herd immunity, and therefore the virus can't do any more damage. The real downside of this, of course, is that that's taking a view on that there is an acceptable level of casualties with that. If we move on to the next slide. Now, what this really means, and a lot of the stuff that we're going to touch on today is not, it certainly isn't meant to be political, but there are aspects of, and I think it will become more apparent in the coming months and any future review, of the political aspects of decision making that have gone into designing responses. But when we come down to our individual positions and our individual responses to this, you could see it from the outset of the pandemic. The real issue, the biggest issue I would suggest we're dealing with, is fear. And legitimately, you know, fears for physical health, money. Look at the rush on food and resources. And it says something, you know, quite typical really about the British character, that the two things we looked at were both alcohol and toilet roll were the two main things, that and dried pasta, which were the runs in the supermarkets. But a legitimate fear about family and friends, children, parents, these sorts of issues. So if we move on. Which comes on to actually the traditional way that the human brain deals with fear is, and you might have heard of fight or flight, but there's a number of other issues or other ways that the human brain sort of deals with things, from the amygdala. So you've got fight, flight, freeze, flop, and you know, try and be friends with something or a threat. And the real problem with this pandemic is that none of these responses actually work with the virus. You can't fight it, though the language around fighting the coronavirus and we're in it together, etc., actually is quite helpful, because it sort of gives the impression that somehow we can control it or make decisions which will sort of somehow curtail the risk of it. We can't run from it, it's everywhere. And it's very interesting at the beginning of the pandemic as well, that some, you know, a number of very rich people were sort of setting themselves up on private islands and down in shelters. Well, unfortunately, when they come off the island or come out of the shelter, it will probably still be around. You can't really freeze, because once you sort of freeze and sort of play dead, it just keeps there. You can't, when you sort of come round, and likewise with flop, when you come round, it's not gone anywhere. So, and you can't make friends with it. So this makes it very challenging for how we actually deal and cope with those fear responses for what's actually going on around us. Next slide. And if we look at some of the issues which are going to, you know, sort of enhance these problems, We've been looking at loneliness, lack of space in self-isolation. Pre-existing conditions have, first of all, exacerbate the response to if people do catch the virus, but almost have been put on hold. And the big fear in primary care is that actually pretty much a tsunami of both mental health cases coming through, but also physical health issues which haven't been addressed during the pandemic. And the other issue here with isolation is actually separation from the workplace. We are actually, at the end of the day, we're communal animals, and we like being around other people. And the creation of these sort of isolations mean that actually we're much more in an internal world, probably more than we've ever been before. If we move on, Glenn. Next slide. The impact on the body. I touch on the underlying conditions, but all of us, it's been very difficult for people to look at our diet, exercise.
John, can you hang on a second? There's a couple of people wanting to come into the waiting room and my computer's having a bit of, just bear with me 3 seconds.
No worries.
Thank you. Hi, hopefully those who've entered the waiting room are on now. Apologies for the trouble that you've experienced this morning. Could I just ask that everyone mutes their microphones? Thank you very much. Apologies, John, go ahead.
No worries. So some of the issues in terms of the impacts on the physical body is around diet, exercise, breathing, sleeping. All of these things, if we move on, are then also we've got other issues around relationships and our interactions with other people, such as family and friends, work colleagues, and the community. Now there have been, and I would highlight, it's not all sort of negative in terms of, there are positives that have come out of it. And one of the positives that I would suggest I would like to see going forward, and we all would hope to see go forward and continue, is there has been a refocus on community relations. There's more people sort of saying hello to each other, they're doing each other's shopping. You can see it every Thursday when people go out and clap on the doorstep for carers and for the NHS. But there's these whole sort of different facets of our lives have come under huge pressure. Next slide. So how do we deal with them? And what people tend to do is they use coping mechanisms. Quite often they become destructive, which actually make them feel good in that short period. And this is really where our approach, with having worked with addiction and mental health issues, much of what we do is really around working with chaos. It's about putting structure into chaos. And you can immediately see the parallels with the environment we're living now. But we were also seeing an exacerbation of issues around alcohol. Alcohol Change a few weeks ago and did a survey which showed that around people admitted to around 33% drinking more than they've ever done before, a huge increase. In the first week of lockdown, alcohol sales went up by 28%. Drugs are quite interesting, both in the use of prescription and over-the-counter medications, as well as illicit drugs. And while cannabis has probably been, because it's so widely available, has been, the cannabis usage has jumped up. Actually, an interesting byproduct is actually the access to certain drugs in certain areas, such as cocaine, has actually reduced slightly, particularly where people have had to cross boundaries, cross counties, as part of the supply chain. Not quite the same in situation in London, where there's so much cocaine available anyway. Gambling and risky behaviours. The online gambling industry has boomed during this time. And what we'll all probably experience is a sense that we're either overeating or undereating. Looking for those sort of nice carbs and sort of fatty foods that make us feel good. Sadly, the impact of violence, and particularly domestic violence, there was a report this morning that that's gone up by 300%. And that will just be the tip of the iceberg, because most domestic violence is still not reported or recognised. And what Glenn's already touched on is, with the report from the charity in Durham, is the incidences of self-harm and suicide, both of which we're dealing with high numbers beforehand, and personally within our own service, because we've done a lot of work with the aftermath of suicide with both individuals, their families, and their work colleagues. We're expecting a huge increase in this. In fact, the University of Sydney is predicting an increase of around 25% increase in suicide rates going forward. So if we move on. And all of this sort of context is in the sense of this huge blanket of background noise. Now, this one, if you look at social media, you look at theories around 5G masks causing coronavirus, you've got people denying it's even happening, or that it's a government threat to sort of impeach, impact on democratic rights, or you've even got certain world leaders suggesting that you inject disinfectant. But what's really interesting, the background noise actually muddies the waters quite considerably. Now, I picked this as an example because actually this is a fake Twitter account, but it sort of summed it up for us, that it was in the sort of social media driven world that we're living in, there are plenty of genuine examples of very similar situations and comments like this, including one I saw from a Hugo Boss model, who has always been a model, who was saying he didn't believe the calculations around the R rate, basically because he didn't understand them. Now, in itself, that might be, it's not pointing the finger or sort of laughing at sort of the sense that you might be able to comment on everything. But it does highlight the fact that actually this person has something like 2.5 million followers on his social media pages. And that's where it does start to matter. So if we move on to the next slide. So facts become really important, and not alternate facts, but actually, tested and data that we can actually make judgments on. So if you look at the UK, and I primarily will talk about the UK and then hone down or really onto the northeast of England to give you an insight. But the UK's got the second highest death rate in the world. Sweden has the highest death rate per capita, but certainly the UK, only above us is the US. But if you look at the figures that have been quoted, even in Parliament yesterday, anyway, you get figures quoted from 32,000 just in hospitals. If you bring in the care homes, etc., it's up to 42,000. But actually, if you actually look at the real, what is likely to be the closer figure, with ONS projections as well, for areas where people or data where people have died, but those figures haven't been quoted in the official figures, we're probably well over 60,000 by now. And the true number of people who've died won't be known until, we're into, if not the second wave, probably second or third wave, or after the pandemic finally dies down. As of yesterday, 312 NHS and care workers have died, which is unprecedented, that health workers are dying from the very conditions they're meant to be sort of supporting or treating. And it changes the relationship in work about psychological safety, about how even a hospital cleaner walking into work, their relationship and that view of where they're going, what that could impact, and would they see their families again, etc., etc., has totally changed the psychological contract between employer and employee. And when we start looking at that as an example of people returning to work as lockdown eases, that is a major factor for people to realise that actually this is a hugely stressful and fearful time. The other factor, an interesting one, and I was talking to quite a lot of labs last week, and we are hearing it now from a number of labs even this morning, that actually, although testing capacity has actually increased, and there's lots of talks about we'll have the capacity for 200,000 tests a day, etc., etc. The reality is actually the numbers of tests carried out each day has actually dropped. So the capacity is there, but the tests aren't happening. And there's a number of reasons for that. But if we move on for a moment, what this really says to us is there's a number of things that we just don't know. And this is why facts become really important. The very first is that we really don't know how long antibodies stay in the system and how easily triggered these could be by re-exposure to the virus. Now, some research from South Korea would indicate that actually it's unlikely that people re-exposed to the virus will be sick, but there have been some odd cases, outlier cases around the world, including in Japan. We really don't know the levels of long-term immunity and whether that actually, this might just be for a few months, it could be permanent. And that, again, the research from South Korea has been quite positive, but it's too soon to say. The real risk is we really don't know the impact of asymptomatic carriers and what are called super spreaders. So on the latest research that we've seen is around 40% of people who will pick up the virus, and I'll come back to this, will show no symptoms whatsoever. The variants of COVID I've already touched on. In Wuhan, they've identified 30 different strains, possibly with different impacts. And there was a report that came out, but it's not been sort of properly verified, that the strains that have hit Europe are slightly different to the ones in the States. And they're actually slightly, supposedly, it's a milder version in the US and in the Southern Hemisphere as well. But actually, the ongoing research is indicating some interesting variables, such as, for example, BMI and what demographics you're in, what sort of ethnicity people are looking at, and the impact it has on different community groups. And the big one we really don't know is how many cycle or waves of the virus we're likely to experience. All the evidence and consensus shows that we probably have at least one more. And it's usually with second waves, they're much more severe than the first wave. So next slide. So before we move on to this section, Glenn, I noticed there's some questions come through in the chat room. So it might be useful if we had a little chat, talk about those before we move on.
Yeah, that's great. Thank you, John. I mean, incredible, very insightful in terms of the information today. We've had a couple of emails come through to my email address, but also a couple on the chat. Just a couple, I'm conscious of time. The first one, John, do you think that the government strategy around communication is being undermined by social media?
The UK government strategy?
Yeah. Yeah.
Right. I think there's two things. I think the problem is the government strategy has been incredibly confused. And whichever way we cut it, whether we start testing, then we stopped it in, mass testing and tracking was sort of initiated and then it was stopped 2 weeks later. The approach on care homes and reintroducing people before they were tested back into care homes. The strategy itself is, as somebody summed up, is actually, it would appear there almost hasn't been one. Now, I think that's slightly unfair. There has been a strategy, but I think it's the wrong strategy. And the strategy for the guidance that we followed, because we've been working with clients for commercial clients, we very much looked at WHO guidelines and really what's gone before in places like South Korea, etc., who have looked at testing, tracking and isolating. And we just haven't done it. And we've come to it so late in the day that the virus, we really don't know what the future impacts are.
Yeah.
So it doesn't help with social media to answer the question directly, but I think it just highlights the importance of having a really clear evidence-based strategy, and then clear communications.
Yeah, I mean, it doesn't help with all the confusion, just as a for instance around schooling, does it? You know, in terms of the schooling and the government, you know, are saying, well, you know, we're trying to do it early June, and even, you know, in the northeastern Teesside, we're seeing already governors and councillors and local bodies are saying they don't feel as though they're ready, you know, so they're challenging the communication because it's not clear enough.
Yeah, well, I think there's also a fundamental point, Glenn, which I'll just make this point because I think this is really important. Where countries have looked, if you look at an international comparison, where the countries who really got on top of it, places like New Zealand, Taiwan, South Korea, Germany, have gone on top of it, is that the approach has been actually very directive. It's like, we're going to do this, we're going to do that, we're going to do this. And then people actually are seeing that it's done. What's actually shifted, if you take the schools situation as an example, it was almost, well, we're going to lock down, but it's, you might want to, you know, there's a choice in the matter of what goes ahead. And it's also not looking at the international evidence of lockdown and reopening places like schools. So there will be a lot of fear around it, and I think it's almost put a lot of pressure, particularly on teachers, the teaching professions, on the academies, and on governors, etc., as well as on parents, that they're almost, the feedback we're getting is almost people are feeling that they're being somehow expected to make the decision on whether this should go ahead or not.
Yeah, no, I see. I mean, no, I mean, great. Thanks for that, John. I mean, some really good questions. I think the worthy of taking a little bit more time, actually. Some really good things here. First one, I mean, it might be difficult to answer. I don't know if you've got statistics and analysis at hand, but in respect to coping mechanisms and destructive behavior, are we seeing this more within those not working or those working under pressure, such as those in, you know, key services such as, you know, the NHS and waste and refuse collection, things like that?
Yeah, it's certainly all the feedback we're getting, and it's an interesting one because there isn't any collective data set being pulled together to look at this. But certainly the impression that and we're going to come on to what the situation was like before COVID in a minute. But what is interesting is if you look at, we're seeing a number of unprecedented things. So the trend for drinking actually hits across all sectors, be it people furloughed, and it's almost like there's a fear of what's going to happen, will they ever be brought back to work? But also, it's almost like we've gone on to as if this is an extended holiday period. Yeah. And the problem is it's been extended. It's almost like over Christmas, what do people do? People eat and drink too much. But this has gone on now for 3-4 months.
Yeah.
What is unprecedented is the levels of mental health conditions coming through in health staff. So we've had, when you've got a serious problem when you have A&E consultants taking their own lives, and we've had at least one down in London, but there's been a number of suicide attempts.
I mean, to be fair, that links in very nicely with the next question, John, if I can. There's two more which I think have to be, you know, posed to you. Definitely, I think they're really good. So the high UK death rate will almost certainly directly impact on the fear factor that the UK population are feeling, and in turn the level of destructive behaviour that we see, perhaps. So as this is driven by the UK's kind of herd immunity approach, are we likely to see additional funding to support those with mental health that have been adversely impacted?
I would certainly hope so, because if you look at what the Royal College of Psychiatrists are looking at, and I'll come back to it, they've 43% of psychiatrists working, and these are people working at the sharp end.
Yeah.
They've reported huge increases in crisis management going forward with people sort of just really not being able to cope. But what's the really worrying figure, which sort of taps into the issue around funding, is, and mental health services were poor beforehand, they've actually even more stretched now. But you're actually looking at around 45% of routine appointments haven't been met. Now, what that means is those people are sort of storing up these issues going forward. So certainly, definitely, if there's a time to look at an increased funding for mental health services. I mean, we're a mental health service where we offer that to business, for example.
Yeah.
And we've seen just the demand, the level of inquiries, people asking us to run EAP lines and things like this, which we do, is the level of inquiries are through the roof. And so I think everybody expects and understands that this is a major issue. The real issue is, will funding be put in place to support it?
Right. Yeah. Okay. No. Very. Yeah. Excellent. It's sort of, you know, it's still very much the unknown, isn't it? Currently. Another question. I mean, you may want to come on to this later as part of the presentation, but you decide. Question coming in from Andy: does testing identify all known strains of the virus?
As far as we know, it does. And but what's interesting, it's more about the issue with the strains is they don't not really understand sort of viral load, things like viral load, how long the virus will sort of stay on surfaces, those sort of issues, rather than sort of necessarily whether testing will sort of identify a particular strain. It's more the impact of the virus that's the issue.
Right. Okay. No, we've got more, John, but I think with time, I think we'll progress, and maybe we'll see if we can take some more in the next session. Thanks.
Great. Okay. Well, look, we've talked about, and that sounds a fairly grey, you know, I think it's a fairly realistic sort of assessment of where we are now and how it's affected us. But, you know, to think about, to plan for the future, we've got to really be clear on where we've been. So if we move on to the next slide, where were we before the pandemic? So if we just touch on a few stats, when we do our normal training on drug and alcohol and mental health issues in the workplace, and I won't run through all of them, it's just sort of, you can see a snapshot. What is undoubted is that there is a significant underlying impact of people's mental health and, you know, coping mechanisms, generally speaking, of things like drugs and alcohol. Now, whatever people's personal views of drugs might be, the reality is that they're here and they're here to stay. And it is one of the easiest way of dealing with the situation, which is basically to take pain away. Now, where we see it, there's two factors I would put in. Where we see drug use or alcohol use, and we're talking dependence here, not you talking about social use, but social use can easily tip into dependency. We always will see mental health issues as a comorbidity. And it's quite interesting because really the ways to help someone quite often with an alcohol problem is, it's not the alcohol's the problem, it's the underlying reasons and potentially trauma that the person's using alcohol as the tool. It's the weapon of choice to deal with the situation. But if you look at those figures, they're quite startling, really. And they are also only the tip of the iceberg, because if you take the example of, you know, mental health costing 30 billion to industry, how many people will ever really get a call from somebody who works for them and say, well, sorry, I can't come in today. My anxiety is so bad I can't get out of bed. Or if they phone up and say, I'm sorry, I can't come in today. I used a lot of Coke on Friday night and I'm on me coming down now, but I should be all right for Wednesday. These sort of conversations don't take place. What you're more likely to get on the Monday morning is a dodgy tummy or a funny kebab or, you know, a back pain or a migraine. So actually these figures are an indication, not a set figure to actually work for. And we believe, and certainly it's been evidenced with the companies we've worked with over many years, that actually it's just one indicator of a whole complexity and myriad of conditions how people deal with them. If we move on to the next slide, Glenn. And again, if you look at some more stats, and again, these are all sorts from people like the ONS and various others, there's a realization that actually people do actually know what's really going on. They might not really want to sort of admit the extent of it. But a very interesting study was showing that 27% of employers admit that drug abuse is a problem at work. Now that's interesting in two ways. One is it's higher than many we would have thought would admit. But if we were talking the City of London, for example, and talking about cocaine, that figure would probably be about 99%. So there are regional variations. It is different in different sectors, but actually, as particularly in the case of cocaine, which used to be very much an aspirational, expensive drug, it's actually a lot more affordable since the price dropped about 10, 15 years ago. And there isn't a bar or restaurant probably in the country that you can't get it if you are looking for it. So if you then look at the impact on lost days working, we touched on before, you take the fact that around 75% of regular drug users are actually in employment. And the reason for that is because drugs are expensive. If you then look at people who are in treatment services, around 25% of people in treatment services are in full-time employment. And that's actually a good thing. We're a recovery organisation. But it's important that employers understand what people are bringing into the workplace with them in terms of their own emotional and sort of social baggage, mental health issues, not really about whether people are bringing drugs into the workplace itself, though of course that's an issue. More than 1 in 6 people aged 16 to 24 admit to taking drugs regularly. And actually an ONS study showed that actually 1 in 5 had taken, this was last year's figures, in the first 6 months of the year, 1 in 5 admitted it, but it was probably likely to be 3 in 5 people in that age range had tried drugs in the past 6 months. And then when you talk to insurers, estimate drugs account for as much as 80% of losses due to theft in the workplace. Now that's an interesting figure because I have no idea how they calculate that. But the reason it's there is because this is what insurers, it's one of the factors people will base what premiums you pay in your own businesses are based on these sort of numbers. And the other key one here is, probably from the health and safety perspective, and for this audience in terms of risk, alcohol's implicating 40% of all workplace accidents and 60% of workplace fatalities. And actually, if you look at all the strides that have been made in improving sort of health and safety in the workplace, you can see a key issue, particularly in the UK, which has got a very good record on reducing the number of people killed in the workplace. But actually, you can still see what is a huge factor alcohol and substances will be. And it's not just about being over the limit or coming in. If people have been drinking heavily at a weekend, where is their focus on that Monday morning if they've got a hangover? Or if they're actually they're coming out of that, they're just not firing on all cylinders. And they are the issues that really were there beforehand, which are going to be exacerbated coming forward. So if you move on to the next slide, Glenn. And I just wanted to share a little bit of the extent. I've touched on cocaine earlier, but it's a very interesting little study because it just shows how widely available it is and how widespread it is. There's a very interesting little study with King's and the University of Suffolk, where they tested the water levels in all rural tributaries in Suffolk. And what they found was these little prawns are the smallest signs of life in the waterways. And what they were surprised at was all of them, every sample they tested from these waterways in Suffolk, had the little prawns all had traces of both cocaine and ketamine in their systems. Now, that tells you an awful lot about, if that's in the rural areas, what's it like in London. So if we move on to the next slide, again, testing the water in the Thames. This is with the latest figures that came out before Christmas from UCL, who monitor the water levels for drugs and do the calculations. But this is the City of London, remember, not Greater London. But actually, it was estimated that the City of London uses 23 kilograms of cocaine a day. We had used 5 times more than Amsterdam, 8 tons annually, with a street value of over £1 billion just for the main sort of central London. Now, clearly we're in the wrong business if you can make that much money from this. But if you just take that in as a coping mechanism, that is a really sharp indicator of where we're actually, what is brewing. And also, if there hasn't been a supply or people haven't been able to access it for a period, this is where party time starts, and this is what people will be using, and which will of course increase the risk within the business. Next slide, Glenn. But it's not just about the illicit drugs. I touched on the prescription and over-the-counter drugs earlier. The impact on, the previous few years, really, particularly in the past 10 years, there's been a huge increase in the use of prescription and over-the-counter medications. 1 in 11 people are treated by the NHS with medications that would cause dependency. Prescription drugs are very much taking the place of illicit drugs in pop culture. So if you think what killed Prince, George Michael, Michael Jackson, all prescription medications, primarily fentanyl, but they're easily available and you can buy them over the internet. And particularly for the younger range, they are pocket money prices. So in conversations with a number of particularly private schools, it's amazing how many people now use Xanax and Valium and similar sort of drugs just to help them get through exam periods, for example. Next slide. So I want to just focus, and we'll rattle through these quite quickly. About the North East, if we just focus on the North East for a minute, this is before lockdown. We had the highest number of drug deaths at 77.4 per million. Next slide. Hartlepool and Tyneside are the codeine capitals of the UK. The levels of codeine in cocodamol, over-the-counter medications, is through the roof. And what was very interesting, when the lockdown did take place, there was immediately shortages on products such as cocodamol and sort of the drowsy version of Night Nurse, things like this, which would indicate either people were stockpiling or there's been a huge increase in codeine-based products to help people get through. Next slide. Money Supermarket identified Sunderland as the drink and drug driving capital of the UK. So if you live in those sort of postcodes, that's why your starting premium for driving for insurance will be much higher than anywhere else in the country. Next slide. We've also got the highest use of prescription and over-the-counter medication. Touched on the over-the-counter, but I just want to show you quite a staggering graph if we move on to the next slide now. Because the North East, we've got the highest use of prescribed opiates in the UK. And this table, you don't really need to see much more than if you look at the comparison between London, which has the lowest level, the North East. These figures are from 2010. And actually, they've got an awful lot worse than these. The last figures, I think, were produced for 2016. But actually, the figures have been presented in a very different format. If you were to present them in the same way, then actually the numbers in the North East would probably be another third on top, whereas London has only increased slightly. But that gives you a sort of quick snapshot of what is actually in the community and therefore what is in the workplace. And it's particularly a key issue when you're looking at issues such as workplace well-being, workplace drug and alcohol testing. This is one of the issues that we're seeing all the time. And it's not just, if we bring it onto the mental health conditions, if we move on the next slide. The impact with alcohol and mental health is, it's well established. And the North East, we have the highest level of alcohol-related hospital admissions, highest level of binge drinking, and alcohol-related deaths in the North East. 2015, last time we've had a chance to look at the comparison, were 22% higher than the national average. And that's not just down to different calculations and methodologies on this. If we move on to the next slide. The mental health side of things is we've got also additionally, and now see, this is where you can see there's a direct correlation between the two issues. We've got the highest levels of mental ill health, prevalence of diagnosed depression, Hartlepool, South Tees, Gateshead are much higher than the national average. And this comes back to the 43% of psychiatrists have seen an increase in urgent and emergency cases following the COVID-19 lockdown. 45% have seen fall in the most routine appointments. These are all what will be coming out and waiting for when we get back. And a really important thing is that actually, if you look at the level of prescribing of antidepressants, they have, in England, they have actually increased by 100% in the past 10 years. If you look at the Northeast, which is more comparable to Wales, because this data is collected on national country levels rather than British English regions. The Northeast and Wales are much more sort of fairly similar in terms of demographics. Well, both of those actually would indicate that antidepressant prescribing has gone up by around 300% in 10 years. So what does this mean for us? If we move on to the next slide. What we see in the Northeast, sadly, is we also have the highest suicide rate in the country. And if you look at the increased pressure that was already mentioned a couple of times on services, this is really going to be one of the biggest challenges that employers are going to have to deal with in how do they support employees, either who are having suicidal thoughts themselves or who are dealing with family members who either may have attempted to take their own lives or did have succeeded in doing so. Next slide. And before we move on to, what do we actually do about it? It might just be worth taking, if anybody's got any immediate questions, we could sort of have a quick chat about that now.
Okay, thanks, John. Conscious of time, so I've been a little bit selective in the questions, so apologies for those that have asked them, but as John alluded to, at the end of his presentation, his contact details will be on there. So if anybody wants to contact John directly, please do so. Is that okay, John?
Yeah, of course. And I would like, whenever we do a webinar or something like this, because this can seem quite sort of stark and shocking, some of these debates. We don't want people to, our starting point is always, if you know what you're dealing with, if you know what you're dealing with, you can deal with anything, basically. Yeah. And so we'd like to see this as the start of a conversation.
No, that's great, John. Thank you for that. So apologies for those who maybe questions I'm not airing, but this one, blimey, you could, you could do a whole day's webinar on this, I think. Thank you to Janet for this question. And I mean, I'm going to elaborate on this if I can. John, do you think that people generally understand risk associated with COVID-19 and its impact on day-to-day sort of normal life? Now, for me, when you look at risk, I think of, likelihood and probability. So when you look at likelihood and probability, I suppose what Janet's asking is, do you think people understand, first of all, the likelihood of contracting COVID-19? And then if you were, do you think people understand the potential severity? I mean, I know this is a really difficult question to answer in a couple of minutes, but I'd like certainly your views on that.
Yeah, it's actually not a hard one to answer, to be honest, because there's two different viewpoints. One is we've been working with a number of companies, and to be honest, we're really pleased, and they're really pleased with the success on this, because they certainly understand that we've taken a risk-based approach to sort of managing this in the workplace. So again, it's about probability and impact. It's about severity. And when but that's very different to what you see necessarily in wider, sort of the wider community. And you can see that just by observing in the supermarkets. You could see it on the beaches in the first day release. You could see it on the underground on the first day when people on the Monday told you could go back to work. Yeah. And I think there's two factors for this. One is, I think businesses are forced to and want to look at it from, how do we get to grips with this? How are we going to manage it within our environment, which is the key point. But also, I think there's a bit of through fear and sort of heightened sort of awareness, people get fatigued. And I think people, it'll only when it directly, it's sort of, this is where numbers and the death rates and things constantly, every day being reported. There isn't a news channel that doesn't cover COVID, for example.
Yeah.
It's on rolling news. And I think people get fatigued and it becomes normalized in a way which only then becomes a stark reality when something in their own hemisphere, basically, is affected by it. So I think from a business perspective, I think people are very conscious of this. And you can see that in the approaches to, you know, we've been helping put in things like access control systems in place and things like that. But actually in the wider community, I think people are tired and have lost sense of, particularly where you've got a lot of the background noise with things like social media, but really very unclear directions coming out of government.
Yeah, I mean, what's really fascinating me is, certainly with many of our clients, I don't know about yours, but there seems to be a huge push on risk management and risk assessing return to work COVID-19. But all of the risks on the risk assessment that I'm seeing are potential hazards seem to be more physical ones. For example, social distancing, cleanliness, washing the hands, hand sanitizer, screening, shielding, face masks, all the obvious physical ones. I'm not seeing a lot of risk assessments by employees or employers, beg your pardon, and the government as well don't seem to be picking this up in terms of a psychological risk assessment and the impact on the employees from an employer. I mean, would you agree with that, or do you think?
I would, but I would also say that that's the natural state of how health and safety is applied. HSC is, you know, health and safety is applied in the workplace. Even with the HSC sort of stress risk assessments that were brought in, the vast majority of companies who we speak to really don't know how to apply those or how to develop them.
Yeah.
I think this is where there's a really interesting, and I'm going to give you a really interesting case study later around where, although it wasn't planned, the psychological impact, actually there's been quite a remarkable one. Which I'll come on to, but I actually agree. I think it's the nature of the discipline. We're used to, as health and safety sort of professionals, we're used to looking at and managing the physical environment without looking at basically the people in it and the baggage that they have with them.
It's the classic kind of quote, isn't it? You know, shout safety and whisper health.
Yes, absolutely.
Okay, John, thank you for that.
Okay.
Yeah.
So if we look, okay, so it all seems doom and gloom, etc. Well, actually, there's a lot of issues, and we're still going to talk through some of these issues. But a lot of this comes down to the will of particularly senior managers in companies, and the backing that. I think the role of health and safety is going to be, basically, we're the people who are going to be helping get companies out of this and to bring them through, you know, whatever the wider future is going to look like. So the one thing we do know about tomorrow is that it'll be different from today. And one thing, what we mean by that is, whatever happens, because whether we get through COVID or not, and I'm sure we will, but whether we get through one wave or two wave or three wave, what is sure is there will be other pandemics, there will be other viruses that emerge. And if you only need to look at history, we've been very lucky up to now that if you look at Ebola, if you look at SARS, you look at Asian bird flu, you look at Mexican flu, the avian flu, there's been loads of different viruses, almost one a year. And the real problem with this one is it's got out of hand. And that's the impact. It's gone global. It wasn't restricted in certain areas. And that's the bit that is really going to change the workplace going forward, because we never know if something even worse is going to come out down the line. So if we move on to the next slide. So where we sort of start looking, touched on facts, etc., a number of people have said, okay, where are you looking to for your advice? Where do you look? Where can we go for advice? And I remember we had, luckily we get on very well with our clients. We're really lucky. We've got a really nice bunch of clients we work with. But it means we can be quite open with them about certain views. Now, I remember back in end of Feb, beginning of March, when this was kicking off, and government guidance from the UK, and even later on in March and even April, a number of clients said to us, well, how do we implement government guidelines? And we had to be quite honest. We said, well, we're actually not following them. What we're identifying is actually we would go off WHO guidelines and what people are doing in places like South Korea and New Zealand and Germany. Because if you're looking at the workplace, which most workplaces can be contained in a certain way, you don't want a herd immunity approach brought into a workplace. You'll have no production if something goes down. So the guidelines we've looked at, and after this event, we're going to ask at the end if people would like to, maybe on an opt-out basis. We're doing a little survey, which I'll come back to, but also we're going to be circulating a synopsis or summary of some recent research which has come out, including things like the WHO guidelines, but in particular the Independent SAGE Committee report that came out on the 12th of May, which makes very interesting reading. And we were very pleased that actually when we looked at it thinking, okay, what can we learn from this? We'd actually ticked the boxes that they come through. They're talking at a national level and sort of government level. And we're thinking about, okay, what does that mean for the individual workplace? But we're going to circulate that if anybody would like to see it. Government guidance and guidelines is interesting because although the national policy we might not agree with, because I don't think it helps businesses for the reasons I've set out, actually there are some fairly useful sort of, though they need to be applied, and I would still take advice from professional, people who are doing these sort of risk assessments, etc. Independently. I would get that independent view, to be honest. But there are some guides on the gov.uk websites where you can download this sort of information of how you can approach your workplace. Now, virtually all of that, nearly all of it, is geared to physical environment. So we'll just flag that. And actually one of the simplest ones, the Government of the Republic of Ireland did a return to work document, which is on their website, which actually I found just nice and snappy and easy to follow. But again, you'll notice it's virtually all geared to physical environment. Next slide. So what the new world is, what do we know and what do we don't know? Well, first of all, the assumption that population susceptibility to COVID, although it's not been proven, pretty much everyone is saying it can affect everybody. And that's really important when you're applying sort of the approaches to getting back to work. What we also know is the risk of infection is known to increase with age. Now, one of the clients we work with, I won't mention any of our client names at all, but one from when we were talking to them at the beginning of March, what was very clear was that virtually the whole workforce, it's quite a specialised area, were men in their over 50s. And if they're, as a man in my 50s myself, who probably eats too much and doesn't look after myself as physically as I should, I probably would fit into their demographic, but actually we're the main ones at risk. If you look at the comorbidities of greatest risk, which increase the risk both of access to the virus, but also the impact it has, because the vast majority of people, we've got to remember, will have mild symptoms if they contract it. But actually, when it's not milder, then it becomes really serious. And diabetes, hypertension, obesity, respiratory diseases, etc. What we really don't know is what the long-term impact on the virus on these conditions will be, particularly the respiratory diseases. And a very important point is also, it would seem to indicate that actually the size of the viral load makes a huge difference. So this is why you might have fit and healthy doctors, care workers, nurses, etc., dying from exposure because of the sheer volume of the virus they're exposed to. Whereas most people, and this is the bit that actually still remains to be seen, might be having milder symptoms because they're only coming in contact with smaller volumes. So there's still quite a lot of research to come onto that. Next slide. We've got to face the fact that actually the poorest communities in the UK have fared worst, particularly with death rates. And if we come straight back into the northeast, and this isn't bashing the northeast because I wouldn't live anywhere else, and it's God's own country, etc. But the interesting thing is we can't avoid the fact that we've got huge health inequalities and areas of social deprivation. So if you take Sunderland, for example, has had the highest death rate per 100,000 in the UK. If you look at areas of deprivation, Middlesbrough and Hartlepool being top 10 in Europe, in the UK, many of the wards being the top 10 in Europe, including in Sunderland, places like Southwick. What this really means for the workplace is that if you're a manufacturer in Washington or Sunderland, for example, your workforce coming back in are going to be much more at risk, or have been at risk, not just from the virus, but also from the potential impacts of the virus going forward. And a lot of the issues around things like drinking and smoking and the diet, for example. Okay, next slide. And again, when we start looking at the coping mechanisms, how we deal with these issues, again, it's the ones we've talked about before, about previously, but it's the issues around drugs, alcohol, gambling, physical health, violence, arguments and violence in the workplace, self-harm, suicide. These are the factors that any health and well-being policy that might have been really, if we're being honest, quite often focused on putting some fruit on it on a Friday, are actually going to have to move and really look at more issues around trauma and dealing with sort of fairly complex needs and comorbidities that you'll see with these that come with these indicators. So if you're looking at a really good time to do this, before people return to work, is start looking at the policies you have in place for mental health, for health and well-being, what your drug and alcohol policy is. Because if the level of alcohol use has risen quite dramatically over the past few months, is what is going to walk through the door on day one. And this might be the time to reissue some of these policies, particularly a drug and alcohol policy, before people return, and highlight that almost, this is the time to approach us if need be. Next slide. And I would suggest, again, just to highlight, and this is really to focus in on this, you really have to consider where you're seeing issues of substance misuse. Mental health always goes hand in hand. And I think we've also got to be really careful to be aware of the protections within the Equality Act around mental health and what might come out following the COVID lockdown. Again, it comes back to that very first slide around the responsibilities as an employer to protect the health and well-being of your workforce. Okay, and an interesting point that was made, and we've seen it sadly, there's an expectation sometimes, and we've seen it, how much under pressure the NHS has been. We can see how under pressure the mental health services are. But there's a really interesting point that actually quite often with this pressure is only going to get increased. And I was on a webinar there was a City of London mental health group working with city colleagues down there, and they made a really interesting point. They said actually what they're advising people to do is, if you have an EAP line, which I'll touch on, it's actually worth paying for it, paying for a private one, whoever you use, if you haven't got one in place, as a way of trying to support local services who might be overstretched and might not be able to meet those needs anyway. So it's just a thought, but I thought it was an interesting viewpoint. Next slide. But this is the key thing. I think it really is the time to identify and review your existing resources and use them. EAP lines, most companies, or many companies, will have an EAP line. They're of different qualities. Some have even, we've understood, I won't mention names, have been put on furlough during this time, which was probably the time they're probably most needed. But actually, we really need to review what your currently provision is, because actually you're looking at a very different type of service, as we've just talked about before. The role of mental health first aiders and other mental health programs is going to come in the spotlight, because again, one of the issues there is and we've identified previously, is actually the stress on the mental health first aiders themselves. They're not mental health professionals. Most have been on a 2 or 3 day course, and virtually none of them get a further supervision. In fact, we offer supervision to mental health first aiders in the workplace to act as a safety valve for them, check practice is complete, and check that things aren't being left. But actually, it's a really important time to look and talk to the provisions that you put in place and see how they are and how equipped they are going to be to support all these other issues that are coming through. And useful little tip is, one of the things is shared purpose is really important. So actually a really good point is to look at where people have volunteering and CSR programs, for example, and try and harness that energy and that sort of network and connectivity to both support internally and the wider community. And do think about amnesty periods again. Most people, when they bring in a drug and alcohol policy, for example, launch an amnesty period. These are very different times, and actually you might get a very supportive response. You might be surprised at the response you get by pushing this out before people come back to work, saying, right, if you've got any troubles with drugs, alcohol, or any related issues, please come forward now. You won't lose your job, but we will support you. Because in doing that, at least you can identify what the issues are, and you're not going to find people aren't just going to fall foul of a random drug test in a couple of months' time down the lane, if that makes sense. Next slide.
Okay, 5 minutes, John, if you could. I hate to cut you short. Very interesting, but 5 minutes if you can. Thank you.
Oh, well, we're nearly there.
Cheers.
So, that's some suggestions for an amnesty period, which we'll circulate the slides afterwards, so I won't go through those. If we go on to the next slide. But in terms of priorities, I would suggest companies need to try and understand and identify who have actually been victims of COVID themselves or family members, because we're looking into grief and grief issues there. Try and work and check in on people who you know have existing mental health conditions in particular, but also those who have carer responsibilities, both for children and for maybe older parents. And also on furloughed staff. The research is indicating that actually it's the separation between furloughed staff and those who have remained working is quite a gulf, and it will need some sort of reuniting to reconnect teams. And the really shocking one we've got to actually be aware of is the impact, the likelihood of seeing PTSD from the lockdown coming into the workplace, which I'll mention in a minute. Next slide. So, as leaders, I would suggest that this is a really good time to look at the culture of the organisations we work in. If you don't like it, this is the time to change it. Really look at the supporting your team, etc. Look at what the people need and what's coming in with them. And then actually reassess and evaluate. And if you haven't got programs in place, this is the time to start doing it before people arrive. Next slide. And the key here on all of this is communication. You've got to communicate this now, get it out there. You've got to be able to lead from the front and plan and engage from the outside. And most importantly, if we don't know what's happening, say so, but tell people how you're going to put this in place to get things out there to come to some proper solutions. Next one. And prepare, be aware of physical safety and psychological safety as well. We've got to be prepared for loss and for grief, because if people's attention, and it will be hopefully not the case, but the the expected increase in injuries in the workplace because people's attention span won't be there. I think it's really important that people almost treat everybody coming back to work as having been on long-term sick. You wouldn't expect somebody to walk through the door having been off sick for 3 months and then immediately get onto a lathe or onto another piece of equipment. You'd retrain them, you'd take them through the policies again, and that's the approach we would recommend you do through here. But if you get it right and show support, you can establish a new psychological contract between employers and employees, which I'll come on in a minute. Next slide. And just where testing comes in, testing is a key component in making sure that actually establishing, first of all, identifying and doing the physical sort of test, trace and isolate approach to managing the virus, but also about reassuring people on a psychological level that they're coming into a safe workplace and that they're not going to be impacted and they're not going to affect their own families or could kill people around them. And we had a very interesting case study recently, before we move on to the last slide, where one of the unexpected side effects of the testing that we've been carrying out, quite extensive testing, is that the employer was testing not just the employees, but their families, children, where it was required, etc. And the psychological link, because part of our job was breaking bad news if people were positive. The number of people who said we never knew the employer or X company thought so highly of us that they'd actually invest in us in this way, or that they'd help protect my family. And it was an interesting one where we did some mass antibody testing recently. And as the feedback we got was the morale had never been so high on the site, where people were celebrating, etc. And they said it was the best feeling that they'd come across. So it has a number of different roles, testing, and you've got to find an approach that's going to suit you. So if we move on to the next one, and then I just will share something with you. You're at this moment, this is from day before yesterday, myself, my son, and my wife, we've all been suffering from COVID-19. We've all had coronavirus. But I would, a little hint of warning, because this was our antibody test. This is showing me that finally the IgM antibody comes through, which means I'm no longer necessarily capable of transmitting it, but I'll wait for the IgM to drop a little bit lower. But one of the points that sort of jumped out and struck me, the symptoms that we've experienced are not the ones that are currently either going to be tracked by the government or indeed would be form part of the access controls most companies are putting in place. So, for example, we had no temperature, we had no cough, we had no loss of sense of smell or taste. The PCR test that we carried out, the back to lab, was negative because it was after the point when the virus was active. And then these tests have shown it coming through. Now, without the tests bit, which I identified it, we could have walked onto any site in the UK who weren't testing. So it's a bit of a tale, that something to bear in mind if you're thinking of just that. And temperature check on the gate will protect the workplace. It won't, and you need to look at other factors. So if we move on to the next slide. In summary, all we know is that the environment's going to change, but we do have control of how we change it within our own environment, whatever the advice is outside. Do what you see works for you, and take as much advice as possible and share. This is going to be around for at least 12 to 18 months minimum, possibly longer, and that will mean we have to have new ways of working and living. And the sharing is really important. So if people have got good case studies, please get in touch and let us know how you're doing it and how you're managing it within your environment. And on a final note, move on to the last slide. If people do need any help from us, these are the sort of services we offer. I'm not going to run through them, we'll just circulate them. But please get in touch. We're always happy just to give advice on how to, and also to learn from you on what you're facing on a day-to-day basis. And as a very final point, I would just say we're carrying out a survey which we would like to circulate to people on the webinar today. We're going out through a number of membership organisations, including IIRSM North East. We'd ask people to opt out if you don't want to be involved or you don't want to hear from them. But it's a very short 6 questions that we're asking. trying to get a measure of psychological safety from the employer's perspective and from the employee's perspective takes less than a minute to complete, and we'd be very grateful if you could follow the link that we'll issue and help us to get a better understanding of what's actually what the landscape looks like. Thank you very much. Over to you, Derek. Sorry, Glenn.
Yeah, thank you, John. That was absolutely fantastic. Thank you very much indeed. Look, I know you're an incredibly busy guy at the moment, John, so your time spent not only delivering this presentation, but also designing it and developing it for us is very much appreciated. Some fantastic takeaway messages for our members and non-members alike who are on the call. So thank you, absolutely fantastic. We have run over, so thank you to all those who've stayed on the line. Just as a reminder, we will be posting this webinar onto the IIRSM North Eastern Cumbria LinkedIn site. So please pass on to anybody you know who's had to drop off the call. So, you know, thank you very much for that. And you can access that readily if you need to afterwards. Please take part in John's research. It will be an opt-out, so drop me a line should you wish not to take part in it, but I hope that you do. In terms of a guideline for a psychological risk assessment, if you go back to presentation number 1 that myself and Scott delivered, you'll get an example of what one could look like there, just as a starter for 10. And I think that draws us to a conclusion, really. All that remains is to say another huge thank you to John, and a reminder that next week's presentation, the webinar, is going to be something around communication. We're not quite sure what that's going to be yet, but watch this space in terms of the LinkedIn website. And once again, John, thank you very much. That was absolutely first class.
Not at all, an absolute pleasure. And if we can capture any of the questions that on the chat that we haven't covered, I'll be very happy to sort of knock up a little response, and we can push them out as well.
Will do. Thank you, everybody. Bye. Stay well. Stay safe. Bye.
Bye.